Good morning or afternoon, everyone, depending on where you are. This is Jordan Brandt with JBS International, and thank you for joining us for today's webinar, Meeting the Workforce Challenges of the Opioid Crisis in Rural America. Before we begin, I'd like to review some housekeeping items. Due to the high number of participants on this call, all participant lines will be muted for the duration of this webinar session. If you have any comments or questions, please submit them at any time by using the Q&A feature. To open your Q&A window, please click the Q&A icon located in the bottom center of your Zoom window. If you experience any technical issues during this webinar, please message us using the chat feature, which is located at the bottom center of your screen, or email us at rcore-ta@jbsinternational.com. At the end of this presentation, we request your participation in a short satisfaction survey that will appear in a pop-up window in the middle of your screen. We thank you in advance for your participation in this webinar, as well as the satisfaction survey. Today's presenters are Dennis Mohat, Vice President for Behavioral Health with the Western Interstate Commission for Higher Education Behavioral Health Program, and Thomasine Heitkamp, Co-Director with the Mountain Plains Addiction Technology Transfer Center Network, Region 8, and Professor at the University of North Dakota. Dennis and Thomasine, I'll turn it over to you.
Thanks, Jordan. This is Dennis Mohat, and I'm going to kick us off here. I'm with the Western Interstate Commission for Higher Education, as Jordan mentioned, and its behavioral health program. Just to give you a little background, it was founded in 1955. It serves the 16 Western states and Pacific territories. It promotes innovation, cooperation, resource sharing, and sound public behavioral health policy. We provide technical assistance to the states and local providers. We conduct research and evaluation, and we support planning and quality improvement. And you can reach us at the address below.
Thanks, Dennis. My name is Thomasine Heitkamp, and I'm pleased to be with you today and excited about the work that you're all doing to advance best practice treatment in opioid use disorders. I think this is a very great partnership. The grant that I do is with SAMHSA funding, and it's the Addiction Technology Transfer Center. And I serve Region 8, and my colleague Chris Harzo is in the room next to me, and she is available to answer questions as well. And her effort is focused specifically on opioids, so I asked her to join us today. But just in terms of a quick background, to let you know that the ATTC network is in all regions of the United States, all 10 regions. There's international centers, and there's national focus areas. So I don't want to go into a great deal of detail, except to say that this is something that could support you in your efforts. And we also do technical assistance, we do training, we do a lot of work with our single state authorities to advance some of their needs. The map in front of you provides you with a breakdown. Again, I am Region 8, Mountain Plains ATTC, and we're in blue there, but I know there are people from across the United States that are on this webinar, so you can look at your state and see which region serves you. So I think it'd be helpful, since we do work in opioids as an ATTC, to reach out to your director or co-director in your region to let them know how things are going. I do serve on one of the workforce task forces in North Dakota. I'm serving on that group, so I'm seeing some of the work that you're doing and looking at the deep dive in terms of looking at resource capacity. So pleased to talk a little bit about workforce today with you. Addiction treatment, I just wanted this slide to be put up there as we look at facing addiction in America. Only 10.4% of Americans who meet the diagnostic criteria for a substance use disorder received any addiction treatment in 2019. It's 80% for other chronic diseases like diabetes and hypertension. So what I would like to share is that there is a workforce shortage across the country, not just in rural America. It's more profound in rural America, relative to access, but people are not getting the treatment that they need. And the federal funding coming to opioids is largely a result of deaths and the crisis we're facing. Workforce shortages are more severe in rural America. We'll talk about some reasons for that as we move along today, but it is significant for those of you who are doing this work in rural communities to think about the larger context of access to treatment. And some of the other concerns, there's increased poverty, use of more dangerous substances. Places like North Dakota, where I live, we're seeing fentanyl, illegal drug use among younger populations, medical problems, co-occurring disorders with mental health and substance use, and challenges in adopting best practices. So this support for long-term recovery is also an issue in rural communities. I don't want to overwhelm you, but that really is a list of some of the issues that you're going to be hearing about, I think, or have heard about as you start to do your work plans. Trends are not good. Workforce in recovery field is older than average, so there's more retirements. One of the issues that's come to the ATTC pretty extensively in terms of technical assistance and training is compassion fatigue. Exhaustion is common. They're losing patients. Salaries are low. Whenever a legislator asks me, what can we do? I simply say increase salaries. That helps. Need for a myriad of professions. We really can't do that alone. Chris Harzel, who's with me today, is an advanced practice nurse. We have a psychiatrist, we have psychologists, we have social workers on our team, marriage and family therapists, addiction counselors. We have the full gamut of people working with our ATTC. So that's a critical piece. You'll see the shortages of qualified substance use disorder treatment professionals. As many as half of all U.S. counties and all of them rural have no addiction treatment services. So that's an issue. Here's what the good news is. We know what works. Treatment for opioid use disorder requires incorporating medication and behavioral health counseling, both pieces of that stool. They also include a strong interprofessional workforce. No one can solve these problems alone. We solve them together, and we solve them with bringing our professional hat. Use of integrated care, our ATTC that I just went over does have a slide deck for you describing integrative care that Chris Harzel and another colleague, Mary D. Sjogren, put together. So funds are that I would encourage you to look at, because that website does have a host of resources that could help you, including rural opioid use disorder. As the Affordable Care Act increased reimbursement, it was a problem because we didn't have the workforce. So better use of data. Here's a good report on data that you can click into when you get your slides. So health issues in rural America, physician shortage. Rural communities contain 20% American population, but 10% of physicians practice in these communities. So a significant workforce shortage. Increase in poverty, which I've mentioned. Aging population, increased older population, higher numbers there. And poor health outcomes in rural areas, more likely than urban adults to describe their health as fair or poor. It is not uncommon in a state like North Dakota for people to drive up to 3 hours for healthcare and back to their home. Opioids specific to rural areas, 74% of the US farmers have been impacted by opioid crisis. Injuries are high, and this includes pain medication. People in rural areas is twice as likely as those in urban areas to overdose on prescription pain pills. Rural adolescents are more likely to abuse prescriptions. 60% of the overdose deaths in the United States were opioid related in both rural and urban areas. So we're seeing those same problems. We're also seeing a lot of polysubstance use in the work that we're doing. People aren't just doing opioids, they're doing methamphetamine, they're doing alcohol, marijuana. So opioids might be a focus of the treatment, but we see a lot of polysubstance use. And the thing that affects treatment probably the most is, we're talking about workforce, but stigma, that we have a lot of judgment around substance use. And the slide decks for you that are on our webpage with the ATTC, Region 8 ATTC, Mountain Plains, do have some information about language matters and words have power. I think Dennis picks it up here.
Yeah, so I just wanted to give sort of a 40,000 foot overview of the workforce shortages that you face in developing your plans and also some strategies to address those. If you look at this map, you know, the bottom line here is green is not good. And the darker the green, the worse it is. And as you can see, those rural places in this country have a significant shortage area for mental health professionals. The cold hard facts, 60% of mental health professional shortage areas are in rural areas. 65% of rural counties lack a psychiatrist entirely. There are shortages of all behavioral health professionals, psychologists, psychiatric nurse practitioners, social workers, addiction counselors, mental health counselors, the entire gamut. Most rural Americans get their mental health care from their primary care provider, and 13% of rural counties have no behavioral health provider at all. So what's different? What's about rural that's different that leads to this? Most of you are working in rural, so you know some of this. Rural residents have higher rates of depression, substance use disorder, and suicide than do their urban peers. There's issues on accessibility, which is about getting there and paying for it. Availability, that someone's actually there when you are and needing care. And acceptability, that you have choice, quality, knowledge. And the fact of the matter, all of those things lead to the fact that rural people enter care later with more serious symptoms and require more intensive treatment. So on accessibility, we know that rural Americans travel further to provide and receive services, that Americans are less likely to have, that rural Americans are less likely to have insurance benefits for mental health care. The ACA has improved that, but in many states, there hasn't been an expansion of Medicaid, and in others, now there's the new plans that are available that are more catastrophic, and so people simply don't have the benefits to access the care. Many of the most rural states have the fewest choices in the ACA marketplace, so their care is oftentimes, the insurance is higher. And rural Americans are less likely to recognize the need for treatment and understand their care. And NAMI, the National Alliance for the Mentally Ill, did a survey of folks across the country and found a significant difference between rural and urbans in what's known as mental health literacy or substance abuse literacy. And if you don't know what you have and you don't know where to turn to get the help, and then you throw stigma on top of that, it creates a pretty big crisis. Availability of providers, we've already gone over that. It's a chronic shortage. I did work in this for most of my career. You can go all the way back to the Eisenhower administration's presidential task force on mental health, all the way to today, and about 60% of rural Americans live in shortage areas. So we really have not been able to move that needle, and so it's chronic. It's not getting better. And then when you get to specialty providers, they are highly unlikely to be available in rural areas. So a pediatric specialist in substance abuse is probably not going to be available in your rural community, but neither is someone who has experience with older adults and specific training in older adults. And so the rural areas really suffer from those specialty care areas. And then comprehensive services are often not available, and it's we lack that full range of services and that full continuum of care in rural America. Acceptability is really about the fact that we don't have programs that are specifically training people to work in rural areas. And we don't, and rural people lack choice. There may be one provider. And as we all know, having a relationship with your treatment provider is everything. And if you happen not to get along with that one provider that might be available to you, you're on the road to exercise choice. And then, frankly, when we think about opioids, we have to think about how people enter this pathway. And a lot of times it's because they get injured and they are treated with opioids, and it leads to addiction. And when you look at this map, it's about death rates, but death rates are about trauma. And when you look at rural places in our country, they're pretty dangerous places to live. Farming, mining, many of the professions that exist in rural are among some of the most dangerous occupations in the country. And then the fact of travel. People in rural areas are traveling further distances, which increases the likelihood of an accident in bad weather. And all of those things increase the chance of an injury and increase the chance that you might be treated with an opioid and expose you to that risk.
So I'll jump in here. That's really a great background in terms of what occurs in rural communities. I promised Dennis I wouldn't share a lot of examples, but probably the best example I have is some research I did in the oil patch of North Dakota and Montana, and dealing with law enforcement officers there who required oftentimes to drive people up to 8 hours to access treatment when they know there's a substance use disorder, and to that they're admitted and safe, and then only to get a call a few hours later that they need to go back and get them because they don't meet the standard for care. So that has a lot of complications in it. First of all, it takes law enforcement off the streets. It requires collaboration with behavioral health providers, requires collaboration with primary care providers. So on the mantra of interprofessional, that really underscores it. And in terms of treatment, we use the American Society of Addiction Medicine, ASAM, and we do a lot of training among our ATTC networks on ASAM. And we'll see a slide in a few minutes that shows you a continuum of care. And you will see in rural communities some of the biggest problems: understanding withdrawal, limitations in detoxification, limitations in long-term residential treatment, and day treatment are the most significant. You go to a primary care provider, you can maybe get an assessment, and you can get a referral that requires you to travel extensively, and will you get the full continuum? So workforce is a problem in even your residential treatment facilities, and 82% of rural residents live in counties that don't have detoxification services. So the next slide is a map of ASAM's criteria. If it's working, Dennis, there you go. And this is something that when you're doing work with your treatment providers, they will talk about. There are some other criteria, but primarily people use ASAM. So if you look at that, you will see a whole range of early intervention, the need for prevention services, the need for outpatient, intensive outpatient, clinically managed residential care, medically monitored care. So ASAM provides a criteria. And in the perfect world, we would have access to all of those levels of treatment. And we would have people that could do good diagnoses and they could access that level of care. So strategies to move the workforce needle forward really are partnerships. And this is Dennis's slide. He's going to talk a little bit about this. I added a few things, I think.
Yeah. So I think when you look at workforce planning, there's really, it comes down to, there are those long-term partnerships to develop with higher education to build a local workforce. And when you think about higher education, it's everything from the community college that can help you with a certificate or an AA degree level of a person, all the way up to advanced degrees. That takes time, and this is a crisis. But it's good to make those relationships. It's important and vital to begin to build that workforce. Obviously, the certificate level can be a lot quicker at that at the community college level, but you really need to know your universities and what they're training in and develop those relationships. And I think it's so important to have applied learning experiences in your community. So those students that are in those programs are doing practicums, they're doing internships in your treatment programs. That way, when they get out of school, they actually know about your programs and know about the work. And I often tell people this: if you aren't doing training in your community, why would anybody ever look there for a job? I mean, and I say, think about K-12 education and all of those student teachers that we run through the schools, and we usually keep the best of them. So it's really an important part. The next step is really to expand the skills of your existing workforce. The people that are out there doing this work in the healthcare industry, in the mental health industry, in the substance abuse industry, and others. And that's to, training those people in motivational interviewing, in SBIRT, using Project ECHO and ECHO-like training to be able to support those people that are deployed in our rural communities, to be able to learn new strategies, to be able to staff cases and receive mentoring. And then finally, looking at ways to explore alternative providers, people that we're not thinking about right now, but to develop paraprofessionals. In Alaska, they use village behavioral health aides, and they have a whole competency-based training program for those village behavioral health aides, because you're never going to get a master's degree person deployed to some of those small villages in remote Alaska. In New Mexico, they use a program that uses promotores, who are natural helpers in the community health workers and others, to expand their skills. Partnerships with those existing private providers and to use them as extenders of your capabilities. And finally, the waivered providers to support medication-assisted treatment. And last but not least, using telehealth to reach into places where there's an oversupply of providers and getting those people to reach out via technology to serve your population.
I spent some time on the HRSA webpage because I know your funding comes through HRSA, and saw a great deal of capacity to help with workforce. Again, all of these items do require partnerships in your community, and they require expertise. So Project ECHO, which Dennis just went over, really provides a model for technical assistance to enhance healthcare capability. So we do quite a bit of work, our ATTCs do, with Project ECHO and expanding capacity. And the goal of this is to not only present content like we're doing today, but an opportunity to provide an example of a case and how you might work through that case using expertise. And this really has assisted with our medication-assisted treatment providers, our behavioral health providers. Right now, we're doing a several-part ECHO series on non-pharmaceutical pain management as part of our ATTC. We have, and ECHO is typically small, but we have 137 people registered for an event on non-pharmaceutical pain management tomorrow that we will be hosting. We do work on motivational interviewing and SBIRT. The team at the University of North Dakota really cut their teeth on SBIRT, screening, brief intervention, and referral to treatment, being a big part of the prevention as well as treatment leg and access. And that's one thing that I would ask all your providers when you're doing workforce. Are you doing SBIRT? What's your understanding of SBIRT? SAMHSA put a lot of money, Substance Abuse and Mental Health Services Administration, to training the workforce. We trained social workers and nurses and did some work with physicians, but how are they implementing that in practice? And this is a critical piece when we talk about workforce. At the universities, we train them on these topics, and we train them to do this work, and we offer coursework. But if they can't use it in practice, that becomes an issue, and they lose those skills. The Clinical Consultation Center is very interesting. We have something we call On the Spot, with our ATTC that's very similar to this, providing confidential clinician to clinician support and having a warm line. So when you're running into that really difficult case, having a resource that you can call. The National Health Services Corps have been around for a very long time, and we use this for loan repayment. We leverage this through local universities. It really is helpful and encourages people to move into rural communities. I've been a professor at the university for 36 years, and I can tell you that if we can get people to move to those rural communities, they will find things they like about them, or they will give them a couple years and move on. But giving them an opportunity to work in that setting, you will very much be a generalist. You will have to work with resources. You can't get siloed very easily in those rural communities. And we also, and this is my idea of what would happen in a perfect world, that all of our physicians, our nurse practitioners, physician assistants would have their waiver when they graduate from our program, that they would complete the course. Physicians, it's not as extensive for them. It's, I think, just 8 hours. Chris can correct me if I'm wrong. But, and more time for our advanced practice nurses and physician assistants. But if they come out with that waiver, they will be more prepared to work with substance use, and they will also have a better understanding of the disease process of substance use as a disease, on how stigma affects that, and how they can support folks. One of the consultants that we've used talks about doing MAT in his state, and he said, you know, they feel better in a week. And that's what got me engaged, because my patients feel better. So we really need to think about career paths in healthcare that involve a better understanding of addiction. We talk about a needle we need to move, people accessing treatment, removing some of the stigma of accessing treatment, and ensuring that they have supports to do that. And oftentimes that requires supervisory supports. One of the things that has created, honestly, one of the biggest barriers that I've seen in the years I've been working in substance use is the lack of portability of license. So if you're licensed in one state to do addiction treatment, or you're licensed as an advanced practice nurse, if that license can be portable to other states. I sit in my home a stone's throw from Minnesota. I'm in Grand Forks, North Dakota. How can my licensure in North Dakota, I'm licensed as a social worker, be portable into Minnesota? And that's been a barrier that I think our guilds, our licensing boards really need. I'm going to go out on a limb, they need to be challenged about that. So opportunities, we find that when our students graduate and they go out into the field, if they can get additional certification, that is a motivator for them, additional training. And now we know, as you're doing today, that you can hop on your time zone. It's a little after 1 o'clock here for me, and you can learn a little more, get access to slides. That technology helps us, webinars, all those things help us get access to information and training. And then again, my mantra about increasing wages, which I gave an exclamation mark. And rewarding rural practice with loan forgiveness, access to training, and having good bandwidth. That's very much an issue if we're going to do more with training and do telehealth, that we have good bandwidth. North Dakota is pretty good, but some states in my region, in the region we work in, aren't as good. So those career paths at no cost if we need folks in the workforce.
So one of the things that, Thomasine talked about was, enticing people who are trained in urban settings and urban-based institutions to come to rural. But one of the things that we really push for amongst our partners in the West through WICHE is really shifting the lens from that of in higher education. We oftentimes call people who live in rural areas away from our institutions as being place bound. And with that comes a connotation that somehow you're trapped by rural America. And we really need to shift that. And we need to think about people being place committed and how we can extend through technology higher education to people that are living in rural areas. And I will tell you that in my experience in working in rural, looking at who you have already working for you that has great people skills and great talents that you could support to train up to be that provider in the future, and really going after strategies to do that. There's a lot of ways. In the old days, we used to talk about this as distance education. Today, we tend to call things like this technology enhanced teaching and learning, because it both helps you extend the teaching to people that are remote, but it also helps them learn. And so there are so many tools available to us today that both help you as a learner and help you as a teacher, and to make courses accessible and to create, as I mentioned earlier, local supervised practica and internship. We have to get people experience in rural. We used to joke, for a little older than probably many of you, and we used to call a lot of rural experiences in higher education the Brill cream approach. A little dab will do you. But what we really know is that you need a lot. You need to get people out to rural. You need to get education out to rural so that you really get place-committed people that will stay. We need to develop an academic ladder that aligns with that career ladder that Thomasine mentioned. And part of that is articulation from certificate to degree, that you can start at that local community college and you can progress to degree without a redo. And that is the biggest bugaboo in higher education, is those individuals and those programs where you take a class in statistics at your local community college, and then you matriculate into an upper division, and they tell you you need to take that statistics class over again because, well, you know, that wasn't as good as ours. And we just need to get rid of those kinds of barriers, because every time you put a redo in front of a student, it increases the likelihood that they will not progress towards degree. And so we really need to think about that articulation. And it's not an easy job, as Thomasine, who works in a university, can tell you. You know, to get the Department of Education, the Social Work School, and the College of Liberal Arts to all agree upon a common core curriculum for folks that no matter which school that they take that in, that it'll count in the other school, is a hard lift. But we need to align with that career ladder. As you get more skills, as you get more training, you should earn more money. And it's one of the perverse issues in mental health care is we reimburse somebody fresh out of school the same amount of money that we reimburse somebody that's got 25 years of experience and great outcomes. And so we really need to think about how, as you grow as a workforce, we reward that. Finally, we have to stop blaming the why people leave. People leave rural places, for opportunity. You know, most rural systems are very small, and it's hard to move up in those systems and make more money. And so people usually most often leave because there's a better opportunity somewhere. And people stay in rural places for a life. That's where you can balance those opportunities with a life that you're living and the ability to earn a living. And when there's balance there, then people don't leave. And it's an important thing to keep in mind.
We have seen that telehealth can be very effective in helping with the opioid epidemic. It's increased the demand for behavioral health services and exacerbated the behavioral health workforce shortage. It disproportionately burdens rural and underserved areas, because when you think about the complexity of helping and assisting someone struggling with a substance use disorder, you know that there's a limited access, there's stigma, and in some of our rural communities, there is a stigma related to where they might see their car, which video conferencing room they might be in that is for people struggling with substance use disorder. Some of our, and this really underscores the importance of integrated care where you can go to one healthcare center. So the reasons for access limitation include, as Dennis mentioned, the lack of specialty in substance use disorder treatment and primary care physicians with experience in behavioral health. I would add to that advanced practice nurses. When we're talking about rural communities, I have seen in my state and in the Region 8 that we are looking at advanced practice nurses with prescription authorities really filling a void where we won't see that specialty care come in, where we won't see psychiatric nurse practitioners, for example, being able to assist and other kinds of specialty in the advanced practice nurse area. So in addiction, privacy concerns are big. Stigma concerns really remain pervasive. And I really hope that for those of you who have not looked at the Language Matters handout, that you go to our ATTC webpage, there's a link provided here, and look at some of the slide decks for you that talk about stigma and the role of stigma limiting access to treatment everywhere, but particularly in rural communities where we know everyone. I grew up in a town where my family was 1/10 the population, and we had 10 people and there was 100 people in the community, and everyone knew what everyone else was doing. So telehealth can really connect people that are geographically dispersed. And I was excited to have a bookmobile in my community, people coming in with books. But now we think of the power of the internet and the fact that I'm speaking to you today from Grand Forks, North Dakota about topics that I feel passionate about in terms of workforce and access and looking at promising approaches. One of the providers that works with our Technology Transfer Center does a lot of work in psychiatric telemental health. It reaches out to an IHS facility, reaches out to federally qualified healthcare facilities, and it really can do that work of advancing behavioral health as well as medication-assisted treatment. And even in some of our urban areas, we will hear as someone's doing an induction and that they will want some support. And I heard a story from Massachusetts where someone was doing some work with an adolescent population in MAT and feeling nervous about that and was able to call someone to get supports on the spot. Chris, anything you would add as you unmute here and talk a little bit about the role of telehealth and generally workforce in rural communities?
Hi, can you hear me?
Yes.
Okay. Well, thanks for asking. Yeah, I mean, I think telehealth, one of the things that I was just thinking about as you were speaking, Thomasine, was the stigma in rural towns and not wanting to, especially related to addiction and substance use disorders, is people don't necessarily want to drive up and have their car be parked in front of a place where they know they might be getting treatment for something that they want everyone in their business. And we've run into that in some of our smaller clinic sites. So I think having, we have an integrated setting, so there's lots of reasons you could be parked in front of our clinic, and we're adopting some telehealth kinds of things and integrating services within the larger context of a primary care visit, I think has helped address that. In terms of workforce, yeah, we certainly have experienced that. We're an FQHC, so we don't always, we're not necessarily always competitive with pay for a lot of disciplines. We have found that really being creative in terms of what our team looks like has helped. We have mostly advanced practice nurses. We have some physicians who work with us a little bit. We adopted a collaborative care model, so we have a consulting psychiatrist who reviews cases. He doesn't see patients, he just reviews cases for us on a weekly basis, just via telephone or video chat for the most part, and provides advice so that we can keep some of our more severe persistent mentally ill patients within our clinic walls and not have to refer them or have them wait to see other disciplines, in particular uninsured patients. That's been super helpful. We use students. We partner with our local universities, so I was glad that Dennis mentioned that. We have psych interns and social work interns and people working and seeing patients and helping us. That staff that helps us. We can see more patients on days that we have students helping us out. And then again, the licensure, we're working to, in North Dakota, get a licensed addiction counselor on board, and that is no small feat. So there's a lot of barriers to bringing on team members too. So, and again, a lot of us came on board not knowing how to do all this or how to work in a team. So as much as we can model it outside so students can see it and be teaching it in school, I think is really important. I hope that addressed your question, Thomasine. I can talk more if you want.
No, thanks, Chris. That's great. And Dennis, I thought it was important for you to hear from Chris because she's doing that on the ground and is affiliated with the university. And so Dennis, is this your gal? Is this your Katie and Karen?
No, just a random mom and grandma and daughter. No, but I think that I wanted to, before we toss this to questions, we really wanted to leave 15 minutes so we can deep dive to help you with some of your questions after giving you this overview. But I wanted to reiterate that, you know, the rural workforce, and those of you that are working in rural, you pretty much know this already, but I just wanted to reiterate the importance of charismatic leadership, that one person really does make a difference. Some new blood coming into the community that's excited and wants to do a good job, that makes a big difference. And one person that's been doing that for a while who retires and moves on or leaves or passes away leaves a big void, and the progress that you've made over years can just fizzle overnight. And so you really need to treat your workforce with respect and care, and know how important they are to everything, and that it's very fragile. And to keep that in mind, and to embrace growing your own. Really embrace the notion that making an investment on people who are already place committed is an investment well made. So we left 15 minutes. Boy, we hit her right on the nose. We really wanted to leave 15 minutes to be able to answer your questions. And so I believe Jordan or Bethel will forward those questions to us. Is that right?
Yeah. Yes,
Okay.
That's right, Dennis. Thank you both so much. At this time, we will begin the question and answer segment, as Dennis mentioned. If you have not done so already, please submit your questions by using the Q&A feature located at the bottom center of your screen. We will also launch the poll that will appear in your window, which includes 4 short evaluation questions. So please take a moment to fill those in. The first question we have is, you mentioned loan forgiveness. Right now, opioid treatment programs are specifically excluded from the rural loan forgiveness program. Any news on changing this?
I have not heard of anything, but I would refer you to your HRSA program folks who can sort of work that through HRSA, who runs the National Health Service Corps. But certainly work with your state legislatures. Most states have used both the National Health Service Corps, and they also have state loan forgiveness programs to get those included. I think as you're planning since these are planning grants, as you're planning where you're going to locate these professionals, locating professionals that are eligible in a interdisciplinary setting where perhaps part of their work is with addiction, and another part of theirs is with an area that is covered under loan repayment. There are different ways to skin the cat, as they say.
And this is Chris. I just typed in the link into the chat. I know that the National Health Service Corps has the SUD workforce loan repayment. That's, I believe, is newer this year, and it expanded the disciplines that could apply, and specifically pertains to those working with patients with SUD. So that's the newest one I know about.
I'll jump in. Yes, it expanded. I know the social work and those professions working. And the BWIT program, some of those programs that we're working with at universities have been very successful.
I see this question from Brian Williams about using community health workers, and what skills would you suggest? I mean, the first thing I would train folks in is, first I think I would get them up to speed on SBIRT and motivational interviewing. I think other things like mental health first aid, to get a broader picture. There are those kinds of trainings that are out there. Certainly if you're working in tribal communities, I know that there's a push within the IHS to make the curriculum that's been developed by the Alaska Native Tribal Health Centers for village behavioral health aides, that there's been a push to make that available to other IHS regions to train local workers. And so I think that if that training in fact does become available through the IHS, that's an exceptionally well-developed competency-based training program.
Thanks, Dennis. I see, yeah, you can see the questions too. The next question we have that came in is, do you have any suggestions for resources in working with law enforcement on these issues?
I'm going to jump in because I think that's a great question, because they're often ignored. They're on the front end of this. And in some of our rural communities that do not have access to detoxification services, any type of withdrawal management, they're often in squad cars or in jails. And I think the challenge for all of us is, as we look at all these money coming in to do technology transfer and training, is to include law enforcement in that training and to engage them, whether it's mental health first aid or whether it's a better understanding. One of the people on our staff at the University of North Dakota traveled to all the jails in the state to educate them about withdrawal management. And those kinds of models need to be replicated as much as possible. Obviously, we want them to carry Narcan, naloxone. We want them to do certain kinds of understand some of the risks and do harm reduction. But we also want a more robust and more engaged training.
I'll add too, Thomasine, that we parole and probation officers have become one of our biggest referral sources in our primary care office. So I would say, in working with jails and parole and probation to ensure seamless sort of returns so that they can get back on appropriate medications or get back into counseling.
Great. The next question we have is from someone who has hired numerous licensed professional counselors, but these individuals are not able to bill Medicaid for mental health services. Do you see any changes for this due to the opioid public health concern coming?
Well, Medicaid is state specific, first of all. And so if you know one state Medicaid program, you know one state Medicaid program. So every state is different. And that's the first thing to understand. And so you really need to, that's really a local effort, and to work with local advocates and your legislature and the folks that run Medicaid in your state to expand that, because I can tell you that in some states counselors can bill Medicaid and in others they can't. So it's something that's really locally driven and driven by the state Medicaid plan.
I would add one more thing that I learned last week when I was in Denver. our Region 8 office, and we're all divided into HHS regions, does have a Medicare and Medicaid office, and they have someone that sits in that regional office that is state specific on Medicare and Medicaid in each of the states. And it's my understanding that other regions might have that same access. So reaching out to your regional administrators for HRSA or SAMHSA, all of those folks, you know, we spent a lot of time with the HRSA administrator in Region 8 last week, reaching out to them and finding out what kinds of supports they can provide in the technical assistance and training that you might be offering, sitting right within your region.
Great, thank you. The next question is, how do you see the field being impacted once the workforce department is moved under the Department of Education at the federal level?
Boy, you know, that's not something I've thought a whole lot about. And I mean, I've seen a lot of reorganization in federal and state government across my career, and usually it's just moving chairs around. I think that, you know, in the best scenario, there becomes a closer tie between workforce and education. And that plays out in the states. I mean, right now, you know, there was always a disconnect between things like voc rehab and education and Department of Labor. So, you know, time will tell. I think it's something that we have to pay a lot of attention to.
Thanks, Dennis. The next question is, Vermont, Maine, Rhode Island, and Maryland have all created 1115 waivers, which have created opioid treatment health homes and provide additional funding for the team-based approach. Is there any data showing an effect on workforce expansion following the additional reimbursement for non-physician services?
You know, in prepping for this, I think Thomasine and I both looked at the literature, and nothing really jumped out about that, but that's getting sort of down specific. HRSA does operate the rural health research centers, and so and there's one at the University of Southern Maine in Portland. So it might be something for if you went on the HRSA Rural Health Research website and contacted those folks at the University of Southern Maine, that or the RUPRI Center, which is centered at the University of Iowa. Both of those centers do a lot of work around rural impacts, and so that might be an interesting question to pose to them.
Great. And then the last question we currently have in the queue is, what strategies have you found successful in working with sites or providers that say they cannot afford to set aside the time to pull staff off the floor for things like expert or motivational interviewing, et cetera?
And Chris can maybe chime in too. What we have found in the assessments that we have done is that people manage unbillable hours in this field. So how do we adjust for that? So short trainings, effective trainings that meet their needs, and sometimes it is over noon hour, so they can have a lunch and learn. The focus of our ATTC is learning in the workplace. So using technology to provide responses that are helpful are our best opportunity, and asking people to leave their agency for several days to attend a training is not as effective as providing that training on the ground in a manner that allows them to continue their work. So workplace learning.
I would agree with that, and it's just it's worth it. And if there's also the other side of people not thinking they have time within their day to do ESPER NMI, and it can be brief. It pays for itself. There's data to support that. I just think it's getting buy-in.
Awesome. So that concludes all the questions that we currently have. Thank you, Thomasine, Dennis, and Chris, for your time today. If you have not yet completed the survey, please take a few moments to provide us with your feedback. And just as a note, there have been a number of questions and comments around the National Health Service Corps. We will be hosting a webinar with some of the folks from the HRSA office that runs the program in March. So please keep an eye out for that invitation, as I think they'll provide some really great resources. Additionally, we've had a number of participants send some helpful links. So we will make sure to include those in the email when we distribute the recording and copy of the slides for this webinar. So with that, thank you again to our presenters and have a great rest of your day, all.
Goodbye. It was great being with you. Thank you.
Yep. Have a good rest of your day.